All right, this is the final part to the respiratory system.
System. So let's talk about how respiratory gases are transported in the blood. So you have oxygen transport that we talk about first. So the molecular oxygen is carried in the blood two ways. A small amount of it, 1.5% of it, is carried or dissolved in the plasma. The lion's share of it, the majority of it, is carried attached to the iron of a hemoglobin molecule in the red blood cells. So 98.5% of the oxygen is transported this way. So the association of oxygen and hemoglobin. So each hemoglobin molecule, if you'll remember vaguely, we talked about this in blood, is composed of 4 polypeptide chains, each which has an iron-containing heme group. So each hemoglobin can transport 4 oxygen molecules. And a typical red blood cell has 250,000 hemoglobin molecules. So roughly each red blood cell is transporting 1,000,000 oxygen molecules. When it is carrying oxygen, we call it oxyhemoglobin, or the hemoglobin's carrying oxygen. And when it has released that oxygen, it's called reduced hemoglobin or deoxyhemoglobin. The loading and unloading of oxygen is facilitated by or caused by a change in the shape of the hemoglobin. So as the oxygen binds, the hemoglobin changes its shape and it increases its affinity or how much it likes oxygen, so it's easier for it to attach. As the oxygen is released, the hemoglobin shape changes and causes it to not like the oxygen so well, and it's easy for it to be released. If all 4 heme groups are carrying oxygen, we say that that hemoglobin molecule is fully saturated. If not, it is considered partially saturated if only 1 to 3 of the hemes are carrying an oxygen. The rate of loading and unloading is regulated to ensure that we have adequate oxygen delivery to the cells. So the factors that influence the hemoglobin saturation are the partial pressure of oxygen, things like temperature, blood pH, the partial pressure of carbon dioxide, and the concentration of BPG. So what is the influence of oxygen, the pressure of oxygen on hemoglobin saturation? So this is what heavily influences the oxygen does, the binding and release of oxygen with the hemoglobin, the pressure of it does. So the percent of hemoglobin saturated can be plotted against the concentrations of it, and you end up with a not linear graph. You end up with an S-shaped or sign-shaped graph, and that's referred to as the oxygen hemoglobin dissociation, and that's what it looks like in the very middle there. What about the influence of the oxygen on the hemoglobin saturation in the arterial blood? So the pressure of the oxygen is about 100 millimeters of mercury, and it contains 20 milliliters of oxygen per 100 milliliters of blood, so it has a 20% volume. In this case, hemoglobin is typically 98% saturated. Further increases, like if you were to breathe in real deep, only are going to produce a minimal increase in the binding of the oxygen. In the venous blood, the pressure of oxygen is about 40% and contains about 15% volume oxygen. So the hemoglobin, surprisingly enough, is still 75% saturated. So it's a misnomer when people think that all of the oxygen is released at the tissues. Your blood, even when it's in the venous side, is still carrying a pretty good amount of oxygen, and we call that the venous reserve. That's any oxygen that remains in the venous blood that still can potentially be used. And so they're showing you the dissociation curves in the lungs and in the tissues. Some of the other influences or factors on hemoglobin saturation: an increase in the temperature, hydrogen ion concentration or the pH, the pressure of carbon dioxide and BPG can modify the structure or the shape of the hemoglobin molecule, and that can cause a decrease in the affinity for oxygen, so it doesn't like oxygen as much. This is what occurs in the systemic capillaries. This also can enhance oxygen unloading and cause a shift of the oxygen hemoglobin dissociation curve to the right. This decreases in these factors shift the curve back to the left and decreases the oxygen unloading from the blood. So just looking at body temperature here. So the optimal there is against 38 degrees Celsius. And so you see the percent saturation at 38 degrees Celsius. And then as you change that body temperature, you can see the percent saturation changes. That's hard to say. Here it is when we're talking about carbon dioxide. So when we have normal arterial carbon dioxide, you can see what happens to the saturation of the hemoglobin compared to when you've got increased and decreased amounts. BPG is produced by the red blood cells during glycolysis. BPG levels rise when the oxygen levels are low. So as cells metabolize glucose, they use oxygen. That's the whole idea of cellular respiration. And in doing that, they cause increases in the pressure of carbon dioxide and the hydrogen ion in the capillary blood. That declining pH, because remember hydrogen ion is an acid, and it causes the pH to decline and creates a condition called acidosis and increases the pressure of the carbon dioxide, causes the hemoglobin oxygen bond to weaken, and that is referred to as the Bohr effect. So the oxygen unloading occurs when where it's needed the most, and so that is always the idea. We just don't unload oxygen at the tissues randomly. It's where we actually need the oxygen unloaded. Heat production in active tissues directly and indirectly decreases the hemoglobin's affinity for oxygen, which allows the oxygen to unload easily into active tissues, which is exactly what you need. Some homeostatic imbalances. Hypoxia is when you're not getting enough oxygen delivery to your tissues, and that can result in cyanosis or the bluing color around the lips and the beds of the nails. Hypoxia is based on cause. So anemic hypoxia is when you don't have enough red blood cells, or they are abnormal, or they're not carrying enough hemoglobin. Ischemic hypoxia means that you have impaired or blocked circulation. Histologic or histotoxic hypoxia, the cells are unable to use the oxygen. This is what happens with metabolic poisoning. Hypoxemic hypoxia is abnormal ventilation, which is an indicator of pulmonary disease. And then there's carbon monoxide poisoning, which is a really, really important thing to understand. This comes from the combustion of gasoline or from a fire, from burning things. Hemoglobin has a 200 times greater affinity for carbon monoxide than for oxygen. So essentially what happens in carbon monoxide poisoning is that the hemoglobin attaches to a carbon monoxide molecule and your brain reads it as oxygen. So it reads it as being saturated and it doesn't have any oxygen at all. And so when you go to drop the carbon monoxide off at the tissues, you're dropping off carbon monoxide, but there's no oxygen being dropped off. So essentially the tissues starve. What about carbon dioxide? So carbon dioxide is transported completely differently, and you may have learned that hemoglobin carries oxygen to my tissues, and hemoglobin carries carbon dioxide back to my lungs, and that's kind of true, but not really true. So it's partially true. So 7 to 10% of the carbon dioxide is dissolved in the plasma. 20% is bound to the globin portion of the heme molecule, not the hemoglobin, not the heme portion, and it's referred to as carbaminohemoglobin when that happens. But the lion's share of it, the majority, is transported as bicarbonate ion, or basically Alka-Seltzer in the plasma. So the formation of this bicarbonate involves carbon dioxide combining with water to form carbonic acid, which quickly dissociates into bicarbonate and hydrogen ion. So the majority of your carbon dioxide is carried as bicarbonate ion. So they're showing you the formula for how that happens, and this is occurring primarily in the red blood cells. There's an enzyme involved in this called carbonic anhydrase that reversibly and rapidly catalyzes this reaction. In the systemic capillaries, after the bicarbonate is created, it's quickly diffused from the red blood cells into the plasma. The outrush of the bicarbonate from the red blood cell is balanced as the chloride ion moves into the red blood cell, and that's referred to as the chloride shift. And so that's what they're showing you there, what's happening, the chloride shift. In your pulmonary capillaries, the process occurs in reverse because everything's backwards in the lungs, right? So the bicarbonate moves into the red blood cells while the chloride moves out. The bicarbonate binds with a hydrogen ion to form carbonic acid. The carbonic acid is split by carbonic anhydrase into carbon dioxide and water, and the carbon dioxide diffuses into the alveoli, and you breathe it out or exhale it out. Okay, so they're showing you what's happening there. The Haldane effect, the amount of carbon dioxide transported is affected by the partial pressure of oxygen. The lower the pressure of the oxygen and the hemoglobin saturation, the more carbon dioxide that can be carried in the blood. Reduced hemoglobin is going to buffer the hydrogen ion and forms carbaminohemoglobin more easily. That process encourages carbon dioxide exchange at the tissues and at the lungs. At the tissues, as more carbon dioxide enters the blood, more oxygen dissociates from hemoglobin, which is the Bohr effect. And as the hemoglobin oxygen releases oxygen, it more readily forms bonds with the carbon dioxide to form carbaminohemoglobin. What's the influence of carbon dioxide on blood pH? This is the important part. Carbon dioxide is a gas. It is an acid. All right, and so it's going to drive the pH down. So instead, that's why it can't just transport freely in the blood. So the carbonic acid bicarbonate buffering system is what is going to be put in place to help resist the changes in the pH. If the pH of your blood goes too low, you can die real quickly. So if the hydrogen ion concentration rises, excess hydrogen ion is removed by combining it with bicarbonate to form the acid, which dissociates into carbon dioxide and water. If the hydrogen ion concentration begins to drop, the bicarbonate dissociates and release hydrogen ion, and then that is considered an alkaline reserve of carbonic acid bicarbonate buffering system. So basically, this is what keeps your pH of your blood from changing while we're carrying carbon dioxide. Changes in your respiratory rate and depth affect the blood pH as well. So slow, shallow breathing causes an increase in the carbon dioxide in the blood and results in a drop in the pH. Rapid, deep breathing causes a decrease in the carbon dioxide in the blood and causes a rise in the pH going towards 14. The changes in ventilation can help adjust your pH when the disturbances are caused by metabolic factors. So breathing is the major role in the acid-base balance of the body. So how do we make sure that we don't have too low of a pH of our body? In other words, we're moving towards the acidic end. We breathe or blow off that carbon dioxide by breathing. So there it's showing you oxygen release and carbon dioxide pickup at the tissues. Okay, that just flipped by the BioFlix video that you can watch. All right, so how do we control respiration? So respiratory rhythms are regulated by higher brain centers, chemoreceptors, and other reflexes. The neural control involves neurons in the reticular formation of the medulla oblongata and the pons. You have a medullary respiratory center. This is a little cluster of neurons in two areas in the medulla. There is the ventral respiratory group and the dorsal respiratory group. The VRG, or the ventral respiratory group, is what's responsible for generating the rhythm. It's also an integrative center, and it consists of a network of neurons in the brainstem that extend from the spinal cord to the junction between the pons and the medulla. It sets eupnea, which is your normal respiratory rate and rhythm of 12 to 15 breaths per minute. Its inspiratory neurons excite the inspiratory muscles via the phrenic and intercostal nerves. And expiratory neurons inhibit the inspiratory neurons. Then you have the dorsal respiratory group, or the DRG. This is a network of neurons located near the root of cranial nerve number 9. And so this group integrates input from the peripheral stretch and chemoreceptors and then sends that information to the VRG neurons. And other than that, they don't know much about this group of neurons. Then you have a pontine respiratory center, obviously in the pons. So neurons in this center influence and modify the activity of the ventral respiratory group, or the VRG, and these act to smooth out the transition between inspiration and expiration and vice versa. So you're breathing in and out, and it's nice and flowing back and forth. This transmits impulses to the VRG that modifies and fine-tunes your breathing rhythms when you're talking or when you're sleeping or when you're exercising. Lesions in this area lead to apnoeistic breathing, which the patient takes, where the patient takes prolonged inspirations. So it's showing you the location of those different clusters of neurons that we were just talking about and what they do. So the generation of the respiratory rhythm. So the actual origin of breathing is not really understood. There is a hypothesis that says that there are pacemaker neurons in the VRG that control intrinsic rhythmicity. The most widely accepted hypothesis is that it's a reciprocal inhibition of two sets of interconnected pacemaker neurons in the medulla that generates rhythm. Each neuron set controls the other to ensure rhythm. The depth is determined by how actively the respiratory center stimulates or recruits the respiratory muscles. The greater the stimulation, the greater the number of motor units that are excited, which increases the depth of inspiration. The rate is determined by how long the center is active, and both are modified by changing demands within the body. The respiratory centers are affected by chemical factors. They're affected by the influence of higher brain centers. They're affected by pulmonary irritant reflexes and the inflation reflex. So the chemical factors, this is the most important of all of the factors that affect the depth and the rate of your inspiration. So when you have changing levels of carbon dioxide and oxygen and the pH, those are the important things that are happening. So the levels of these chemicals are sensed by a central chemoreceptor that's found in the brainstem. There's lots of them in the brainstem, and then peripheral ones, which are found in the aortic arch and the carotid arteries. So what's the influence of carbon dioxide? This is the most important, most potent, and the most closely controlled. So carbon dioxide is really, really important. Again, because if you get too much carbon dioxide or have too much carbon dioxide in your blood, which is called hypercapnia, it accumulates in the brain and it joins with water to become carbonic acid. Carbonic acid dissociates, it releases hydrogen ion, which causes a drop in the pH, which means that you increase the acidity of the blood. Increased hydrogen ion stimulates central chemoreceptors of the brainstem, which synapses with respiratory regulatory centers, and the respiratory center increases the depth and rate of breathing, which acts to lower the carbon dioxide in the blood by having you breathe it out more, and the pH goes back to its normal place. If the blood carbon dioxide level is too low, respiration becomes shallow and slow. So apnea is breathing cessation that may occur when the carbon dioxide levels drop abnormally low. Swimmers are classic for doing this. They voluntarily hyperventilate to allow them to be able to hold their breath a little bit longer. That causes a drop in the levels of carbon dioxide, which causes a delay in respiration, and the carbon dioxide levels are needed to build back up. So even though we talk about carbon dioxide, being a bad thing, you do have to have a certain amount of it. Doing this idea of holding your breath and then voluntarily hyperventilating and all that sort of stuff can cause dangerous drops in the levels of oxygen. So you got to be careful doing that, make you pass out. So this is looking at changes in the carbon dioxide that regulates ventilation in a negative feedback mechanism. So some homeostatic imbalances. Hyperventilation is when you increase the depth and rate of breathing that exceeds the body's need to remove carbon dioxide. You actually blow off too much carbon dioxide, and it may be caused by anxiety attacks. So it leads to decreased levels of blood carbon dioxide or hypocapnia, and this causes cerebral vasoconstriction, cerebral ischemia, and results in dizziness and fainting. Some early symptoms, if you've ever hyperventilated before, you know exactly what this is about, is when you start to feel tingling in your hands and in your face. And the treatment for this is just the age-old idea of breathing into a paper bag. Basically, you breathe off too much of your carbon dioxide, so if you can collect it in a paper bag, you can breathe it right back in. What about the influence of oxygen? So peripheral chemoreceptors in the aortic and carotid bodies are going to sense how much oxygen level is in your blood. When you have declining oxygen level, this normally only has a slight effect on ventilation because you have a huge oxygen reservoir bound to hemoglobin. Remember, you have 75% of it still bound in your venous blood. So this requires a substantial drop in your arterial oxygen below 60 millimeters of mercury to stimulate increased ventilation. When excited, chemoreceptors cause the respiratory centers to increase their ventilation. And so it's showing you this idea of how the nerves are associated with this. The pharyngeal branch of the glossopharyngeal is what is reading this information off the carotid body in the at the split between the internal and external carotid. What about the influence of arterial pH? So pH can modify your respiratory rate and rhythm even if carbon dioxide and oxygen levels are normal. This is mediated by peripheral chemoreceptors. So when you have a decrease in the pH, that can reflect a retention of carbon dioxide. It can also mean that you have an accumulation of lactic acid or excess ketone bodies. The respiratory system controls the attempt to raise the pH by increasing the respiratory rate and the depth. So just basically try to blow off that excess carbon dioxide that's probably causing the pH issue. So a summary of these chemical factors. Rising carbon dioxide levels are the most powerful respiratory stimulant. Make sure you asterisk, star, highlight that. It is all about the carbon dioxide. Normally, your blood oxygen levels affect breathing only indirectly by influencing the peripheral chemoreceptor sensitivity to changes in carbon dioxide. If your arterial oxygen levels fall below 60 millimeters of mercury, that becomes a major stimulus for respiration. But remember, you have a huge reserve, so it's pretty hard to do that. And changes in the arterial pH resulting from carbon dioxide retention or metabolic factors act indirectly through peripheral chemoreceptors. But we also have influences of higher brain centers. So hypothalamic controls, this acts through the limbic system, remember your emotional brain, to modify the rate and depth of respiration. So for example, breath holding that occurs when you're mad. Little kids do this a lot. I'm going to hold my breath. Well, basically what's going to happen is they're going to hold their breath. If they really, really did hold their breath till they turn blue, they'll pass out and they'll start breathing again. Or when somebody's gasping in pain. And also changes in your body temperature change the rate. Cortical, so the cortex can also have an influence on your breathing rate and depth. Direct signals from the cerebral motor cortex that bypass the medullary controls, for example, voluntary breath holding, at least until the brainstem reinstates breathing when the blood carbon dioxide levels become critical. Pulmonary irritant reflexes, these are receptors that are found in the bronchioles that respond to irritants that shouldn't be in there. They should have been filtered out already, like dust and accumulated mucus and any type of fumes. Receptors communicate with the respiratory centers via the vagal nerve afferents, and this promotes a reflexive constriction of the air passages. So basically it knows something bad is trying to get in, and it reflexively constricts those airway passages. That same irritant triggers a cough in the trachea or the bronchia, or a sneeze in the nasal cavity trying to get it out. The inflation reflex, this is called the Ehrenbauer reflex. Stretch receptors in the pleura and the airways are stimulated as the lungs inflate, and it sends inhibitory signals to the medullary respiratory centers to end inhalation and allow expiration. This may act as a protective response to make sure that you don't overinflate your lungs. So here is a summary of all the neural and chemical influences on the brainstem respiratory center, so you can kind of get an overview of everything that's feeding into those areas. What about respiratory adjustments? When you exercise, we have to make adjustments on both the intensity and the duration. So hyperpnea is increased ventilation in response to metabolic needs. So ventilation can increase 10 to 20% or fold times. Ventilation increases abruptly, it increases gradually, then reaches a steady state, and then the exercise stops, and there's a small abrupt decline in ventilation followed by a gradual decrease. So carbon dioxide, oxygen, and pH remain relatively constant during exercise because you're breathing more and blowing off the excess carbon dioxide, and you're inhaling more oxygen. Abrupt increases in ventilation that occur as exercise involves three different neural factors. One is the psychological stimulation. So some people can actually think about exercising and they actually start breathing a little faster. The simultaneous cortical and motor activation of skeletal muscles and respiratory center. So when you actually start exercising, of course, that is going to start the process of breathing faster. And excitatory impulses to the respiratory center from proprioceptors as your muscles are moving in the tendons and joints. A gradual increase in a plateau of respiration reflects reflect is caused by an increased rate of carbon dioxide delivery to the lungs. You got to get rid of it. Ventilation declines suddenly as exercise ends because of the three neural factors are shut off. You have a gradual decline to baseline that's due to a decline in the carbon dioxide flow because the tissues aren't making as much waste product anymore. Exercise leads to anaerobic respiration and the formation of lactic acid. The lack of oxygen in your muscles is not from poor respiratory function, but rather from insufficient cardiac output or skeletal muscle inability to increase their oxygen uptake. What about high altitude? Quick travel to altitudes above 8,000 feet may trigger symptoms of acute mountain sickness or AMS. Atmospheric pressure and partial pressure of oxygen levels are lower at higher elevations. The symptoms of this are headache, shortness of breath, nausea, and dizziness, and in severe cases, lethal cerebral and pulmonary edema can occur. So this is especially bad for us flatlanders, the people that live at low elevations like we do. When we go to high elevations, we can suffer from this a lot quicker than somebody who, for instance, always lives at a higher elevation. Acclimatization, this is the respiratory and hematopoietic adjustments that are made with long-term moves to high altitude. So let's pretend that you move to Denver, Colorado, which has a much higher altitude than Beaufort, South Carolina. The chemoreceptors become more responsive to carbon dioxide when the oxygen declines. If you have a substantial decline in the oxygen levels, that directly stimulates the peripheral chemoreceptors, and what that results in is an increase in your minute volume that stabilizes in a few days to 2 to 3 liters minute per minute higher than at sea level. So it takes a few days, and you know this if you've ever gone to high elevations, like if you go on a ski trip or something. The first couple of days you just feel like you can't catch your breath, but the third or fourth day it starts to be more comfortable for you to breathe, and that's what they're talking about here. High altitude conditions can also result in lower than normal hemoglobin satural levels. This is due to the availability of less oxygen. So when you have a decline in blood oxygen, this stimulates the kidneys to accelerate their production of erythropoietin, or EPO, which is what causes your red blood cells to mature faster. It is a hormone. Red blood cell numbers increase slowly to provide long-term compensation. Some lung diseases, chronic obstructive pulmonary disease or COPD. This is exemplified by chronic emphysema and chronic bronchitis. The key feature is that it is irreversible and leads to a decreased ability to force air out of your lungs. You don't have a problem getting it in, but you can't get it out. Some other common features, this is more common in patients who smoke. 80% of people who end up with COPD had a history of smoking. Dyspnea is labored breathing. They have coughing and frequent pulmonary infections, and most patients develop hypoventilation, which is accompanied by respiratory acidosis and hypoxemia. Emphysema is permanent enlargement of the alveoli and destruction of the alveolar walls that makes the lungs less elastic. There's 3 consequences to this. Accessory muscles that are necessary for breathing, they become exhausted because they use 10 to 15% more energy to breathe than normal. You end up with trapped air that causes hyperinflation, which flattens the diaphragm and causes what's called a barrel chest, and both of which reduce ventilation efficiency, and you have damaged pulmonary capillaries that lead to an enlarged right ventricle. So emphysema is a normal part of aging once you get over the age of 70 or 80 years old. There is a hereditary factor for this as well, but most people who have emphysema because of smoking. Chronic bronchitis is when you have inhaled irritants that cause chronic excessive mucus. The mucus of the lower respiratory passageways become inflamed and they fibrose. This results in obstructed airways that impair lung ventilation and gas exchange. Symptoms include frequent pulmonary infections, and again, risk factors include smoking and environmental pollutants. How do we treat COPD? What are the symptoms and how do we treat it? The strength of your innate respiratory drive is the reason behind the different situations that we've seen. So when you see somebody with COPD, they have one of two situations. They're either a pink puffer, which means the patient is unusually thin because they burn enormous amounts of calories just trying to breathe, but they have nearly normal blood gases. So their skin color is normal. They're just really, really thin. Or you have blue bloaters. These are patients that are usually heavier, stockier, and they have a blue cast to them. They have cyanosis because they have hypoxia. Their skin takes on this bluish hue. What are the treatments for this? Bronchodilators, corticosteroids, oxygen, sometimes lung volume reduction surgery, and then oxygen. So it's talking about the pathogenesis of COPD. Tobacco smoke and air pollution are the two main causes that have this. So we don't have much of a problem with air pollution in this part of the country, but places like Los Angeles, they have really, really bad air pollution problems, and they have people who have COPD there that never ever smoked. For us, the main reason you see people with COPD is because of tobacco smoke, or they could have the genetic form of this condition. And so either way, you have continual bronchial irritation and inflammation and breakdown of the elastin in the connective tissue of the lungs, which can lead to chronic bronchitis, which produces too much mucus and chronic productive cough, or emphysema, which is destruction of the alveolar walls, and the lungs become less elastic, so they lose their stretchiness. In both cases, the you have airway obstruction or air trapnea, dyspnea, frequent infections, which lead to hypoventilation, hypoxemia, and respiratory acidosis. So the moral of the story is stop smoking. Asthma is sometimes classified as COPD, but the episodes are acute, not chronic. So you have periods of time when you are symptom free. So it's characterized by coughing, dyspnea, wheezing, and chest tightness. So active inflammation of the airways is what precedes the bronchospasm. So it's like the tissue that's lining the airways starts to become inflamed, and that's what makes it hard for them to breathe. Airway inflammation is an immune response that's caused by the release of interleukins, the production of IgE, and the recruitment of inflammatory cells. Airways thicken with the inflammatory extrudant, and they magnify the effect of the bronchospasms. Tuberculosis is an infectious disease caused by the bacterium Mycobacterium tuberculosis. The symptoms include fever, night sweats, weight loss, racking cough, and blood in the sputum or the mucus that they're coughing up. The problem with this is that to cure it, you have to stay on antibiotics for 12 months, and most people won't stay on antibiotics for that long. And so they end up with antibiotic resistant strains that are now resistant to multiple drugs. Lung cancer is the leading cause of death in North America. 90% of all the cases are a result of lung cancer. So it is absolutely possible for someone to get lung cancer who has never smoked a cigarette in their life. I have a friend that this has happened to. She has lung cancer, and she has a form of lung cancer that's genetic. She's never smoked a cigarette. But nonetheless, most of the cases are because of smoking. So again, if you're smoking, please, please, please stop. You're young and you can prevent a lot of heartache later in life. Three most common types of lung cancer: adenocarcinoma, 40% of the cases. This originates in the peripheral lung areas, and it develops from bronchiole glands and alveolar cells. Squamous cell carcinoma, which is 20 to 40% of the cases, which rise in the bronchial epithelial tissue, and small cell carcinoma, which contains lymphocyte-like cells that originate in primary bronchi and subsequently metastasize, and that is roughly 20% of the cases. What is the treatment for lung cancer? Early detection is the key. If it has metastasized, it's probably going to be too late. If it has not metastasized, they can do surgery to remove the diseased lung tissue. If it has metastasized, they're going to do radiation and chemotherapy, and there are, of course, lots of new therapies out on the horizon. So that is the end of this chapter, and when you're finished studying all of this fun stuff about your respiratory system, you are ready to take your quiz. Don't forget you have homework, and this particular time you have two homeworks. You have two homeworks to do. One is on the anatomy, and the other one is on the physiology.
Okay, we're finally at the end for this particular lecture, so you need to make sure you do your homework assignments through Connect and take your quiz. Thanks.